Society of Internal Medicine. And thank you to our sponsors, Scottman. So there was a professor of geriatric medicine in Birmingham in 1980, Professor Bernard Isaac, who coined the term giants of geriatric medicine, which means the major syndromes in geriatric medicine like falls, dementia, incontinence, stroke medicine. So about 15 years ago, a new kid on the block appeared, which is called Frailty and Sarcopenia. And there is going to be a tsunami of old people in the next 10 to 20 years. And because of excellent medical care all around the world, Europe, USA, and Pakistan, there will be lots of elderly patients we'll be looking after. So I'm going to talk about frailty and sarcopenia. This is my last posting in Singapore. I worked there for 7 years as senior consultant geriatrician. It was an amazing experience and professionally very satisfying. So as I said, it is the new kid on the block, frailty and sarcopenia. There is an association between frailty and adverse health outcomes like falls, admission to a hospital, admission to a nursing home, and even death. 25% of older people above the age of 85 are considered to be frail, and they have increased risk of falls, disability, long-term care. Frailty is a state of vulnerability to poor resolution of homeostasis after a stressor event, which increases the risk of adverse outcomes, including falls, delirium, disability, and this is a consequence of a cumulative decline in many physiological functions. So this diagram actually gives you basic concept of frailty. And if you understand this concept, you will know what frailty means. In the top of this diagram, the independent patient suffers a minor illness like a fall or a urinary tract infection. There is a decline in function, and then there is a rapid recovery to the baseline function. The green line shows, and compare it to a frail or a elderly person who has frailty or sarcopenia. You can see the proportion of decline is almost 3 times more than a fit, healthy adult. And the recovery to normal baseline function is much longer. It takes a much longer time. So this is the reason why older people stay longer in hospitals, they have a longer length of stay, and they develop more complications. And that is why it is a major cost to the healthcare system in every country. So there are 2 models of frailty described. So I must highlight here that majority of the research in frailty and sarcopenia is done in Canada. The Canadian researchers have taken the lead in this field. Professor from Tallahassee University in Halifax, Kenneth Rockwood, he designed a scale to assess frailty, which is called clinical frailty scale. So this frailty model is called phenotype model. And in a landmark study of Canadian health study, Professor Linda Freed, they established 5 variables: unintentional weight loss, self-reported exhaustion, low energy expenditure, slow gait speed, and a weak hand grip. So according to this survey and study, 43% of the population was considered to be frail. 43% had a mortality, 43% mortality at 7 years. The second model is called cumulative deficit model. As the name suggests, there is accumulation of clinical deficit in these patients. The advantage of this model over phenotypic model is this model gives you the benefit of grading the frailty. You can grade frailty into mild, moderate, or severe. And you can calculate a frailty index. So this was also developed as part of Canadian health study by Professor Rockwood. They developed 92 variables of disabilities which were used to define deficit or frailty. This model expresses gradation of frailty by progressive accumulation of deficits. The frailty index was strongly related to mortality, risk of institutionalization, and death. 10-year survival for the frailest group was 27% versus 70% for the fittest. Frailty was common with age, and by 95, everyone was considered to be frail. Women have a higher mortality and higher frailty index compared to men. How do frail patients present to the clinician? So there are non-specific presentations like extreme fatigue, unexplained weight loss, frequent infections. They have balance problem. They present with falls, balance and gait impairment, spontaneous and recurrent falls. And they develop a psychological syndrome which is called fear of falling. And this syndrome will make their patients so afraid of falling that they will not leave their home. They are housebound. They become prisoners in their own home. They are afraid to get out of the house because they will fall over. Then delirium is also a very common presentation. 30% of the elderly admissions will develop delirium, and a higher proportion of 15% in nursing home residents. They also show fluctuating disability. Fluctuating disability means that they have good days and bad days. If you see the patient in the morning, they are not very mobile and they are not very engaging, but in the afternoon, you see them walking with the physiotherapist in the ward and they're engaging with the nurses and the therapist. Now, briefly to talk about assessment of frailty. I'm sorry, it's a very busy slide. So things like walking speed, less than 0.7 meter per second suggest high risk of falls. Timed up and go test. This is a very validated research tool, timed up and go test. Edmonton frailty scale. Hand grip, which is tested by dynamometer. Electronic frailty index. In United Kingdom, all the GPs are required to calculate every patient's electronic frailty index. So this is part of their quality performance, Confs. Then you review their medication. Patients who are multiple medication, they are at risk of falls. Professor Mary Tinetti in US, she believed that any patient who's taking more than 5 medication is at risk of falling. Clinical frailty scale developed by Professor Kenneth Rockwood from Canada. I'm going to show you the slide in a couple of seconds. Then there is a quick screening tool called FRAIL, fatigue, resistance, ambulation, illness, loss of weight. The most comprehensive tool to assess frailty in older people is comprehensive geriatric assessment, CGA. It can take up to 45 to 60 minutes to assess a patient with comprehensive geriatric assessment. So you can see it is not a very practical tool. So what we do on our wards in UK and in other countries is you collect information on your ward rounds on different days, and by the time your patient is discharged, you have gleaned all the information from physiotherapists, from social worker, from psychology point of view, from the medication point of view, and then you put it together and make it comprehensive geriatric assessment. This is the clinical frailty scale by Professor Kenneth Rockwood. You can see from scale 1 to 3 are fit people, fit adults or elderly people. Between 3 to 6, they are mild to moderate frail people. And this gives you a picture along with the scale. So just looking at a person in a few seconds, you can say this patient is scale 5, this is scale 6. So it is a very quick screening tool and a very effective screening tool. Then from 7 to 9 are the severely frail patients, patients who are wheelchair bound, patients who are bed bound. And these are the patients who are terminally ill and they are dying, in the phase of dying. So there is a very close relationship between frailty and sarcopenia. Sarcopenia means, as the name suggests, like you have thrombocytopenia, your platelets are low, so your size of the muscle is smaller, the power of the muscle is less, and the function of the muscle is less. There are 3 components to sarcopenia, and it's all related to physical frailty. So these slides tell you, this is the cross-section of a normal person on the left-hand side, CT of the femur. You can see there's a lot of muscle around the femur bone. And the next section you can see, there is a lot of muscle atrophy. The muscle is atrophied. So this is sarcopenic person. And this instrument on the bottom is called dynamometer, and this tests your hand grip strength. So all these assessments can be done in your clinic, in your ward. So it is not high-tech medicine. It is bedside clinical medicine which you can do in your clinic setting. I do a frailty clinic in Singapore. I used to do a falls clinic. My nurses would spend 60 minutes with the patient, do all these assessments before the patient will come and see me. So the medicine is practiced so nicely in Singapore. I really enjoyed working there. And I feel Singapore is 10 years ahead of United Kingdom in medicine. I don't know about United States. I cannot comment. Then there is a European working group on sarcopenia for older people. This group recommended in 2018, they produced a document about sarcopenia, how to assess, how to diagnose, and what are the modalities of treatment available. So this group suggests that low muscle strength is the key characteristic of sarcopenia. It is not the size of the muscle, it is the muscle strength, low muscle strength. So it is considered as muscle failure. Like you have heart failure, you have respiratory failure, these patients develop muscular failure. The interesting thing to note is sarcopenia begins in early life. Even your birth weight has a relationship to your sarcopenia. So what are the best tools for sarcopenia? What are the interventions which are effective? Like frailty, sarcopenia is associated with adverse outcomes like falls, fractures, physical disability, and mortality. Muscle strength is a better indicator than muscle mass. The European Working Group on Sarcopenia recommend SARC-F questionnaire as a screening tool for sarcopenia. If the patient is positive on this screening questionnaire, then you can do further assessment for sarcopenia. This is the SARC-F tool. If you score 4 or above, that means there is a suspicion of sarcopenia. These all tools are very validated. As I said earlier, there is a very positive association between birth weight and muscle strength and sarcopenia. There are genetic and lifestyle factors which can hasten the muscle weakness. Nutrition and exercise training seem to slow and reverse this process. Aim is to maximize muscle in youth, adulthood, and maintain in the old age. You would be surprised to know that sarcopenia on diagnosis in emergency department will lead to 5-fold increase in your hospital costs. This is a big thing for all the healthcare providers in Europe, UK, and USA, because everything is linked to your cost, your money. So your hospital bill is 5 times more if you have sarcopenia. In the community dwellers, low gait speed and chair stand tests are supposed to be potential drivers for impaired activity of daily living and lower quality of life. Clinical tools for sarcopenia are SARC-F, hand grip strength, and chair stand test. As I said, all these tests and assessments can be done in your clinic. You just need to train your nurses to do it. So once you have a probable diagnosis of sarcopenia, then you need to confirm your diagnosis with DEXA scan or biological impedance analysis, biophysiological impedance analysis. BIA, it is not very sensitive as DEXA scanning is. BIA is contributed by your dehydration, lots of other factors. So I would personally not recommend to do BIA. I would recommend DEXA scan or an MRI scan. So once you have diagnosis is confirmed with sarcopenia, then you can assess the severity of sarcopenia with gait speed, short physiological performance battery, and timed up and go test. So all these tests are recommended by European Working Group on Sarcopenia for older person. So we all know that there is muscle loss with aging. Diseases like inflammatory diseases, malignancy, organ failure, and neurological disorder all lead to muscle loss and sarcopenia. Inactivity, sedentary lifestyle, spending so much time on your laptops, on your iPads, sitting in front of TV, watching TV and not going out for a walk or doing physical exercise, all contribute to sarcopenia. Malnutrition, undernutrition or malabsorption, medication-related anorexia, which leads to poor appetite and weight loss, overnutrition or obesity. There's another entity called sarcopenic obesity. So if you are obese, it doesn't mean that you can't have sarcopenia. So in 2016, the international coding came into for sarcopenia. So they announced an ICD code for sarcopenia in 2016 on May 31st. So that was a big day for sarcopenia physicians. HOPE was a Singapore healthy older people everyday study looking at prevalence of frailty and associated factors. So why do we need to identify frailty and sarcopenia? Frailty is a dynamic process. So if you intervene early, you can slow down the process, you can even reverse the process to improve the outcomes, health outcomes, and to avoid unnecessary harm. To avoid unnecessary harm, I mean is that if your patient is very frail, for example, your patient is bed-bound, wheelchair-bound, uncommunicative because of stroke disease, then that patient should not be subjected to CT scans, MRI scans. You don't put those patients on intensive care. So this is where you avoid unnecessary harm to the patient. So if your patient turns up to A&E and they have their clinical frailty scale, so the doctors will not do all these unnecessary interventions. They can actually do more harm and distress to your patient and their families. Development of frailty leads to high risk of falls, admission to hospital, risk of admission to nursing home care, and even death. So this study shows hand grip among Singapore residents. So they concluded that older adults in Singapore have a relatively weak hand grip compared to other countries. So this is a very important and very useful slide which correlate the components of physical frailty with the morbidity. So you can see how grip strength is related to fractures, cognitive decline, cardiovascular disease, hospitalization. So you can see grip strength has very close relationship to all these comorbidities. Then walking speed has similarly fractures and cognitive decline and even cardiovascular disease. Chair rise test, similarly related to all these things. So this slide tells you how to find cases, how to assess, how to confirm, and how to look at the severity. So as I said earlier, SARC-F questionnaire, suspicion of sarcopenia, you do muscle strength with grip strength and chair stand test. You want to confirm sarcopenia, DEXA scan, BIE, MRI, and to look at the severity. What interventions are effective? Exercise, nutritional interventions. The important one is protein intake, especially leucine. Correcting vitamin D deficiency, very important. If your vitamin D deficiency is there, you must correct it. Testosterone, very limited role, lot of adverse side effects. Growth hormone similarly has some potential. Insulin growth factor 1 does not seem to improve muscle strength and bone mineral density. There is some evidence of ACE inhibitors to improve the muscle strength. I conclude, frailty means the individual is at greater risk of adverse outcomes after a minor stressor event. Many older people live with frailty and its prevalence increases with age. Detection of frailty should be an essential part of assessment for older people. It is possible to recognize frailty because of the presentation or because of the assessment tools. The most evidence-based tool to detect frailty is comprehensive geriatric assessment. Exercise improves strength. Addressing nutritional deficiency can help frailty. Social frailty is very difficult to measure and treat. Sarcopenia is associated with similar adverse outcomes. Clinical tools for sarcopenia are SARC-F, grip strength, and chair stand test. And all these tests can be done in your clinic. Thank you.